So you must make sure you don't compromise the conditions spelled out in your collective agreement as a member of the GMA. Then 2, you must motivate your workers, the internal clients. Motivation can take several forms. It could be what? Intrinsic motivation or extrinsic motivation. And they serve as means of encouraging hardworking people to continue being hardworking. It also serves as encouraging those who perform below average to emulate the shine example of their colleagues. A mere tap on the shoulder with motivation. We have what's called social capital. Let me give myself an example. When I was working in Koforidua, I had 2 typists. One of them said he was not feeling well. He's go and attend to her son who was in Kibi or Chebi. I asked her, how was your son? And I observed that for about 1 week. There was no eye contact anytime I talked to this lady. So I inquired from her other colleagues and said, oh, she lost the baby, the son, who was about 5 years. It was very painful. And that was why she was behaving towards me.
Sorry, Mr. Mpiani, your network is really unstable. Oh dear, we can't hear you, unfortunately. But we still have a few questions in the Q&A, but we will take Prof. York's presentation and then come back to continue with our Q&A session. I'll crave your indulgence, audience. Let's allow Mr. Mpiani to probably relocate or change his connection and then get a more stable connection and then get back to us.
I've changed the connection. Let's see whether you can hear. Can you hear me now? Can you hear me now? Hello?
Yes.
I've changed the connection. So let's see whether there are any other questions for me to wind up.
There are quite a number of questions. So I'll crave your indulgence, Mr. Mpiani. If you can just stay on for a few minutes, we'll have the next presentation and then get back to the Q&A session. Is that okay, sir?
Okay, I can excuse you. How many minutes should I come back?
I'll
stay on, but I will not be
minutes.
sitting here. I need to stretch.
That's fine. 30 minutes, please.
Okay, so by my watch, is 4:13. So I'll come back at 4:43.
Exactly.
All right. Enjoy your day. I'll come back.
Thank you. Thank you so much for understanding. All right. So, dear colleagues, our next presenter is very well known to us. He's an associate professor of medicine, University of Ghana School of Medicine and Dentistry. He's a consultant physician and endocrinologist at the Kolebu Teaching Hospital, where he's the current head of the endocrinology unit. He's a fellow of both the West African College of Physicians as well as Ghana College of Physicians and Surgeons. And he's our dearest Vice President of the Ghana Medical Association, elected in November 2023. And he also has an MSc in diabetes from Cardiff University and MSc in endocrinology from University of South Wales, UK. Our speaker for the next topic is Professor Ernest York, and he has contributed significantly to research with over 50 publications focusing on diabetes, hypertension, metabolic diseases, and cardiovascular health. Today, he is speaking to us on the topic, the GMA Medical Association Welfare Policy. Ladies and gentlemen, let's receive our Vice President, Professor Dr. Med Ernest York. Prof. York, sorry, the floor is yours.
Thank you. Vera, can you hear me?
Yes, please, loud and clear. And we can see your slides as well.
Sure. I hope my my network remains stable. Let me see whether I can show a minute of my face, my horrible face to the attendees, and then after a few minutes, I'll switch it off.
You're very
so thank you. So thank you once again for having me to be part of today's discussion, and it's always good to be home. Greater Accra is the pioneer. We set the pace and the others follow. So thank you once again. So what we're coming to discuss is the welfare policy of the Ghana Association. It looks like my slides are off. Is it still off?
Yes, your slides are off. I'm not sure.
Your sharing is paused. That's what the screen says. Okay, I'll stop sharing and attempt to share again and see.
Exactly. All right.
Yeah. Okay, it looks like they are back on now.
Not yet. There we go. Yes. Now we see your slide.
Surely. So, GMA is an association, is a trade union, and our mainstay, the ethos, the reason, and the reason that is the welfare of our members. Okay, I mean we do other things, policy advocates, and trying to affect issues in the policy space, especially when health is concerned. But in the main, what we seek to do is to make sure that the welfare issues that our members face are taken care of. So we want to dwell on that aspect today. To be able to do that and bring you to the current state, let me just quickly take you through some history of the association. You and I know, or those who don't know, let me remind you that this association has been around since 1958. And it's the first professional association in this country. So we are the pacesetters. Now, over time, what we did in terms of welfare were piecemeal, right? And on ad hoc basis. It was until 2015 that we first promulgated, the first welfare document that sought to unify all the various, provisions in what we do for our members. Quickly, let me add, the last bullet says that, however, the best welfare policy for any individual, including doctors and their families, should be planned by themselves. I took this from the welfare policy document that we have. And I tend to agree that, yes, the association may step in to help you. A third person, a friend, a family friend, even the government, when we are in need, we go to them sometimes. They may come in, at one time or the other. But ultimately, if you're able to plan for the future or for the unknown situation by yourself, you are, guaranteed to a large extent that you'll be able to minimize the potential negative effects of anything that may happen to you. So these are a list of some of the welfare policies or initiatives that GMA has undertaken or is undertaking currently. The ones highlighted red will be my focus. The GMA welfare policy that was, established in 2015, but we all are aware of the GMA welfare scheme, run by the pension GMA fund, and this was as a response to persons who needed liquid, and of course we also had funds that we wanted to diversify following the DDP. Then we know of the almighty GMA fund, which does not guarantee you a lot of liquidity in the short term, but of course ensures that your pension is adequately catered for. And because of that stringent withdrawal requirements of the GMA fund was why the staff fund was born, which usually, gives you some room to withdraw after your deposit. and then you can also make some investments from that. Now we have currently in the pipeline the GMA Welfare Mutual Health Fund, which I'll be speaking to subsequently. Of course, you cannot talk about welfare of GMA doctors or doctors when you don't talk about conditions of service, so it is key, and that has been around since 2016. Please, the spelling should be service, not support. Then you have a few days ago, we launched the Dynamic application, which is the clinical decision-making tool that doctors are able to use to help them make useful clinical decisions when managing patients. And it's also a tool for research and other things that those of us who are used to up to date, it offers you a similar capability. And what you all need to do is to just subscribe by registering through the link that we had shared since 2 days ago, and then subsequently we'll continue to share to be able to access it. It is for free for GMA members, and we urge all of you to be good advocates for that. For those who are not able to attend or who are not aware, kindly inform them of the existence of this tool that they can use in making useful clinical decisions. Some of the initiatives or welfare initiatives are ad hoc, and I'll mention a few as I go along. We've always been speaking about malpractice insurance. It's something that we've attempted a few years ago, the ministry, through other stakeholders and with the support of other stakeholders. We've had some initial meetings on that. It is stalled a bit, but we hope to revisit it because it is key. It's one of the things that we need to make sure that our members have, so that in case they fall foul of the law in terms of practice, and when claims are made upon them because of such issues, they're able to fall on to be able to redeem their overheads. So at this stage, I will take you through selected provisions in the welfare document that was promulgated in 2015. So the first one is sudden or unforeseen events with loss of job. So this is usually force majeure, things you have no control over. And when it happens to you and you've lost your job, what is GMA obliged to do for you or help you go through the difficulty? One, so what we will do is to pay you a month's basic salary of an SMO for a maximum period of 1 year. So it is not fixed. It has a maximum tenure of a year. The reason being that, whatever you have suffered may be reversed or may not be permanent. And therefore, once those issues are resolved, then the GMA support would also abate. But during the time, we expect that you continue to pay your dues. And then, of course, members and divisional colleagues will provide you the necessary support as well. As a member, what you ought to do when you face difficulties is to draw the attention of the division. Usually, it's best to write formally, and then they would in turn put a cover letter on that and forward it to the national level where it will be attended to. What about sudden unforeseen events with ability to work? So the first one, if you remember, was a loss of job. But if you are still able to work, what will happen is that GMA will support you with a month's basic salary of a senior medical officer, right? And then we would continue to provide you moral support, both at the divisional and the national level. The processes are always the same. You inform your division through a formal communication, and then they would also in turn inform the national level where action will be taken. Right. What about loss of property? Okay. Now, if you lose your property for unforeseen circumstances, so the first one is in the case of loss of house or severely damaged property, which renders it uninhabitable, the division So listen carefully. The division has a role to play, not just to write to national, but they will get a rented place or its equivalent for 1 month. And then the national level would also do same for 3 subsequent months. So as a member, if through an unforeseen circumstance, you lose your place of abode, we are enjoined together with the divisional level to provide you with a 4 months support in terms of accommodation. Let me minimize this. This if you lose a vehicle, then 50% of the basic salary of an SMO will be paid. However, if the member loses vehicle whilst on a GMA assignment, so usually that will apply to officers, either at the divisional level or the national level. Full cost recovery of repairs done on the vehicle or the entire vehicle cost shall be returned to the member if it is not comprehensively insured. So what it means is that the first line will be to fall on the insurance coverage if it is comprehensive. In the event that that is not possible, of course, then GMA will step in to cater for the full cost of the repairs or to replace the vehicle altogether if you were on a GMA assignment. So what about if you have a protracted welfare issue or say events? You know, maybe you have a lawsuit that is not making it possible to work. You know, if that is the case, GMA, of course, would help you, whether in many areas to help reinstate you if it is possible. And then we'll assist you with 2 months basic salary of an SMO if there is a failure to get a job. So that would be a one-off payment. Okay, right. And then you contract an illness that is unrelated to your job. Once that is done, once you have that and we are aware and you make the appropriate communication, so GMA may assist you to secure the entitlements if needed, and then the patient's GMA pays the member 2 months salary, basic salary of an SMO. Okay, so if you have a protracted illness that we need support, GMA may be required to come into support. But if you suffer a work-related illness, then we know that by the laws of this country, the workman's compensation policy comes. And that will be the first line. GMA may be required to support at some point, depending on what exactly the case is, and that will be reviewed, you know. The other provisions of the document that I may not be able to go into detail, protracted illness leading to loss of property, and then loss of family support. All of these have certain provisions that are in the document that GMA is required to do. So later on our various platforms, those of you who don't have access to the document, we will continue to share them so that you can refer depending on the appropriate circumstance that you find yourself. So the next question is loss of life. And I think is one of the commonest requests that come to the national level. If a member dies, what do we do? So the first line is that if you're a member or if you are employed by the Ministry of Health, mortuary services, coffin and transportation of the body to the funeral home usually is borne by the immediate employer. So if it's a hospital, the hospital should be able to bear it, you know. And if it's a big hospital, for example, like Kolegu, the sub-BMC may decide to take care of that. And you have to refer to the workplace applicable conditions, because from institution to institution, there may be a variance of variation in what the local sub-conditions of service stipulates. Then, of course, at the national level, what is required of us is to donate 1 month's salary of an SMO, you know, to you. or of course you are dead, so it will be to your nominated family member. Usually, sometimes we are not too sure who to give because the wife is coming, the son is coming, but we sit back and have a discussion with the larger family and decide where the money goes. But our first preference would usually be the surviving spouse. And then the division is required to write a tribute and also send a delegation to the funeral grounds. And then at the national level, we may also send a delegation. What if it's a spouse? Instead of 1 month's salary of an LSMO, if it's a spouse, the surviving member is given 50%. And then listen carefully, the spouse of a male shall only be one. Okay, so we are not going to pay 50% times 3 in case we have 3 surviving wives if we're male. I'm not sure why the premiums did not add the spouse of a female shall always be one. But these days, you are aware that things are changing, and the ladies sometimes think that they can also do what the men do. But that's on the lighter side. What about the child below 18 years? Again, we will donate to you 50% of 1 month basic salary of an SMO. If you're above 18, our responsibilities are limited and is really restricted to a moral support by the division and also at the national level. So it is with the parents of a member. Now let's be quite clear about what I'm talking. I've shown on the screen now. Members' attitude towards the image of GMA. Illegal fees. If you collect illegal fees anywhere, be it at the workplace, in the church, on phone, through Momo, whatever, and then you get into trouble, please don't really decide to bother us, because we've been at this for many times and many years. We are saying that if you have to collect any fees, try and do that through your institution, okay, so that some understanding is had before that collection is done. Try and provide a formal receipt, and it's best to use institutional receipts. And if you have to pay a percentage, to the institution, so be it, because they probably generated that service for you for which you are claiming the fees. And this also applies to the professional fees that we publish guidelines on. Okay, a lot of the time people want to proceed and do maybe a medical certificate and then put the money in their pocket, but you forget that the sheet you are typing on, the stamp you are using, the office you are in, the air condition you are in, the fan, the electricity, and the patient were all generated or facilitated by the institution. So they are also entitled to a portion of their fee. And that is why we encourage the local associations, to engage management on some of these issues, so that there's clear understanding between both parties that this is the way to go. So that when an issue arises, we know who is at fault, who is not at fault. Please, let's do that. And these days, because of social media, internet, whatever, people are filming us, recording us, and taping us, and publishing them without our knowledge. So you think that you are being smart in one corner, you probably will be unveiled somewhere in a manner that you may not like. So let's take note of that. So again, talking about legal matters, again, negligence issues. If you are found guilty, GMA will give you moral support. Of course, we are obliged. But we know that even those who have been, convicted of crimes, we are provided, gone beyond just providing moral support to actually advocating for the restitution of the sentences, or even gone ahead to ensure that after serving a certain number of years, they are released. Okay, we can do that. But again, why do you want to do things that will put you on the wrong side of law? So let's all be careful. Then if you're undergoing disciplinary proceedings as well, if we are able to, we will support you. And we have done that many times. We have even assisted persons with legal counsel, and in certain situations, even aided some of our members to be transported from different parts of the country to centers where they are undergoing disciplinary proceedings. But you should not take these things for granted or think that GMA will support you when you fell foul of the law. Our support will usually be limited. But remember the psychological toll on yourself, the loss of income, impact on your family and all that is broader or bigger than what GMA can do. So they say prevention is better than what cure. So please let's take steps not to fall foul of the law as much as we can. And we've spoken about this. Okay, so sickness. A lot of our requests also come from persons who are unwell. I mean, usually not from the day-to-day malaria, hypertension. But before I even continue, let me tell you that we've had some senior colleagues who cannot buy their hypertension medicine, and we've had to support them in one way or the other. That is outside these general provisions. That is why I talk about the ad hoc support that we provide. But why do we want to get there? That is why we say it is good to plan for the future now than to wait. And we also encourage all our members to subscribe to NHIS registration. But in case it gets to a point where, of course, you can't afford the issues of about the costs. Sometimes people undergo medical boarding and they are required to be flown outside the country. GMA is usually informed and we step in. Sometimes we provide some financial support ourselves, but usually it is not able to cater for exactly what everybody, the patient, the staff, the member will need. And so we've had to fall on external support individuals, the ministry, even the presidency, in many cases. And it will inform what we'll be discussing later with the GMA Mutual Health Fund, why that came up. And one of the reasons why we are putting together and establishing the GMA Health Fund. Because many of our colleagues, have been in situations where GMA alone is not able to support, So let's take note of that. I think I've spoken about medical boarding where we have had to step in to support people undergo treatment, especially outside the country. And that really sometimes takes a toll on our budgets. And sometimes I have questioned the president's eagerness to help. And it's something that I'm learning from him, that he's quite ready to support patient members who need such assistance from GMA, and even use our own corporate sometimes in the interim before the promised funds from elsewhere comes in. So it's been a challenge on our coffers. Again, if you have a public, one of us being elevated to some certain positions in the country, what we do is always write and congratulate them for the honors they've done to themselves, the nation, and particularly to the association. And those of you who may know, recently when certain of our members were appointed as ministers and others to other public offices, GMA have written to them. The past 2 days, we paid a personal visit, the executives to the National Vaccine Institute to interact with one of our members who made a CEO, to one commensurate with him, congratulate him, and to share ideas on how to advance the mandates of the institute in the area of vaccine provision, especially for the vulnerable in society. We've always had many opportunities, and indeed have actually supported many of our colleagues who have had mental health challenges. It is quite common, and don't think that somebody there are people who are designated or designed to have mental health challenges. No, all of us, because of what we do, the stress we are under, puts us at a higher risk of developing mental health challenges. And in many cases, we've had to intervene directly by supporting them with material and financial resources. And I don't want to go into detail, but those of you who know. And again, it's also a drain on our resources. What we sometimes also do is to liaise with attending institutions to pay part of the cost, although we are always required to pay some, but the majority or the bulk of it. So that is the GMA fund. I'll spend the next few minutes, not more than 5 minutes. I say GMA fund, the GMA welfare package or the welfare document. The next few minutes I will spend on the GMA mutual health fund. This was born from the experiences that I have shared over time. We realized that with certain conditions, it was difficult for the regular NHIS or persons to pay out of pocket. And even those who subscribe to private insurance, it was difficult for them. A lot of it were not covered. So we had to rely on our own coffers, third-party individuals, companies, the ministry, and the presidents. So as an association, we all have agreed that we need to do something for ourselves. And that is why the GMA Mutual Health Fund is being born. Now, it is meant to cover critical illnesses. So it is not for your malaria or hypertension or pneumonia. No, critical illnesses that are usually costly. So what is the definition of a critical illness? Any serious medical condition or a procedure that can have a significant impact on the individual's quality of life, productivity, and longevity. But really, the bottom line is about the cost. Okay. And for now, because we are will be fresh and without much in our coffers, we pegged the maximum support to 100,000 per member. And what are some of the critical conditions that we envisage to cover? Alzheimer's, aorta graft surgery, aplastic anemia, neurosurgeries, treatment of cardiomyopathies, okay, especially the acquired ones, cancers, brain tumors, chronic lung disease with oxygen dependence, those who are in coma, not related to alcohol intoxication. So please take note. If you go on a binge drink and you collapse and you go into coma and they bring you, we will not pay. We'll pay. All right. And then cardiac surgeries, and then the details have been defined: end-stage kidney disease with chronic dialysis, then liver failure, PCI for MIs, major organ transplant, multiple sclerosis. I'm intentionally going through one by one. Paralysis, Parkinson's, endovascular surgery, serious burns, total or permanent disability, hearing loss, for instance, stem cell transplantation, complex lung surgery, endovascular surgery, joint replacements, diagnosis and treatment outside the country, which I've already alluded to. But that has to be medically boarded. It has to be medically boarded so that we know that we are doing the right thing. There has to be value for the expenses that we will be making. Then both medical evaluation via ground ambulance, air ambulance, major maxillofacial surgeries, prostatic enlargement with significant obstructive symptoms, and then ICU care, mental health and psychiatric care to be determined on case-by-case basis, orthopedic treatment requiring major surgeries and implants, spinal surgeries, and conditions requiring rehabilitation. So you realize that this is quite exhaustive. Okay. But they're all serious. I'm trying to go back for you to see the list. They're quite serious illnesses, and it is not your day-to-day conditions that if we push ourselves a little, we are able to take care of. So who qualifies to benefit from the GMA welfare scheme that we will be launching soon? Every member, you have to be active. And then if you're also retired and you are in good standing, you will be eligible, okay? And then we propose, which has been accepted by the last AGC, that we will take 150 cedis per month from as contribution from our members. Then when you join, the waiting period is a year. This thing is to ensure that we build enough funds. Otherwise, before the year will end, 2 claims or even 1 claim alone would deplete the fund. So we need to build it up to an extent that it becomes self-sustaining. What have been done so far? This is just a summary. Currently, we've applied for license from NHIE. We are waiting the issuance of the license. We're also in that process of appointing a scheme manager. We are also securing a space for the scheme, which we've identified within the GMA building premises. That is a national level. We're also following up with Controller and Accountant General to have a source code for the deductions. And then, of course, once we are done, then the monthly deductions will commence. We agreed or secured mandates already during the last ABC to do so. And then once all these things are set, we start the information dissemination, which I believe has started from today. And then we also need to set up a medical advisory board to guide, especially claims vetting and processing, as well as recommendations to the fund board. So to conclude, ladies and gentlemen, what I would have tried to do is to take you through the journey so far in terms of our welfare policy, but highlighting on just the welfare document that was passed in 2015 and the yet to be started GMA mutual scheme. We have seen that over the years, we have endeavored to meet your welfare needs, but it's becoming increasingly costly for the association. We know that the 150 cedis we intend to deduct may not be too adequate, but we look at what members can afford vis-a-vis the programs that we intend to do. Okay. And what we are saying is that support us and share ideas with us so that we're able to reform the welfare processes for our collective good. And also support us to think outside the box. What extra things can we do to improve the welfare of the association? And let's embrace change. But in all of this that we've discussed so far, if you are not in good standing, we beg, we can't help you. Recently, we received requests for some support for 2 members of our association. One was in good standing, one was not. And it was only the person in good standing that was supporting. So let's make sure that we pay our dues and in good standing. And thank you so much, Greater Accra, for indulging me this far. Thank you. I'm done.
Thank you so much, Mr. Vice President, for bringing us up to speed on the GMA welfare package. We are very, very grateful. So please, we'll go back to our Q&A. You can ask questions or make comments on Mr. Mpieni's presentation on customer care or the presentation on the GMA welfare package. So I'll continue. Mr. Mpieni, please, are you here with us? Is Mr. Mpieni back?
We will alert him, please. Thank you.
All right. Okay.
If there are any questions before Mr. Mpieni comes,
yes.
I'm glad to pick them. Yes.
Yes. So I'm just going through the Q&A to see if there's anything on the welfare package. Any questions on the welfare? Okay, so someone is asking, could we get the slides on the GMA fund after the presentation?
We didn't make a presentation on the GMA fund, though. It was a GMA welfare package, but it was a document that I converted part of it into slides and then gave an update on the GMA mutual health fund. But if they want, I can still share, no problem. So yes, if that is what the person wants, I'm ready to share the slides, yes.
Thank you very much. And then someone asked for the link for the Dynamed, and that has been shared.
It's been shared now?
Yes, it's been shared. It's been shared in the Q&A.
In the Q&A, okay. Please put it in the chat box as well.
All right, okay.
The Q&A because of the different questions.
Oh, yes. So Salom shared it. Salom, could you please share it on the share it in the chat box, please? Then from an anonymous attendee, thank you, Prof. York, for such an enlightening presentation, and many thanks to the GMA for its commendable welfare policies. However, I would like to ask, what role does the GMA, as our parent association, play in assisting with the payment of salaries owed to house officers? This is especially concerning in cases where appointment letters have not been issued. Financial clearance has been delayed for as long as 8 months post-induction, and there has been no official communication to the affected individuals. Prof. York.
This is a perennial issue, but from our side at GMA, we continuously deal with it to the best of our ability. So even with the issuance of financial clearance, I will say on authority that GMA or doctors is one of the groups that received earliest financial clearances in this country. You know, I mean, that is a fact because of the advocacy and the engagements that we have with the relevant authorities. So that's respect to the clearances. Now, in terms of payment, you receive a clearance, you don't have appointment letters, or you have appointment letters without clearances. They okay, but whatever the situation is, especially when you've been taken on by especially the big hospitals when they don't have clearances because they need the house officers, we will usually get some undertaking from them or engage them with the leadership of the affected doctors, you know, to get the salaries paid as soon as the necessary documentation is secured. And we always follow up. It's unfortunate that we continue to have these delays, but we still continue to pursue to the best of our ability. I'm just hoping one day that once, you know, your letter is received and your clearance is received, maybe the next pay cycle, you are paid. But let me also say that sometimes it's at the level of the institution, not just the Ministry or Controller or the Ministry of Finance. Some of our HR personnel don't perform their duties well. And again, I also admonish the facility managers. As doctors, we lead many of the institutions. Let's take active interest in some of these issues, especially for our junior colleagues who still may be depending on their parents' stipends, that the HR directorates or secretariat do what has to be done, so that at the national level, when we take it up, things run faster for the benefit of our members. Thank you.
Thank you very much, Prof. York. Then we have here, what percentage does GMA recommend institutions can take from GMA member services charged on patients? Because some institutions are taking 30% of the charges and also take VAT on remaining money coming to the members, which is unfair.
Okay. Well, the truth is that the welfare document does not specify what percentage the institution should charge. But this must be arrived at after due negotiations between management and the doctors. But that must be agreed. If you don't agree, you need to go back. On charging VAT, that I'm not sure what that is the case. This is earned income. So if anything, it has to be withholding tax. So maybe the member is referring to withholding tax, but not VAT. And to pay withholding tax on earned income is statutory outside your regular paid job. So if I go and do locum, for instance, and they pay me at the end of the month, and they take withholding tax of 7.5%, and that you cannot complain, you know, because it is earned income and you must pay a tax on it. But in terms of what the institution retains, that is negotiable. Of course, not recommended by GMA, but you need to negotiate hard. It also depends on what it is actually. Sometimes the institution provides everything, all you need. You just have to sign, and therefore they may be entitled to a larger portion. But in situations where you are, so for instance, somebody is traveling outside the country and need a medical certificate, for instance, and you are really the sole person doing it. It has to be an institutional document. I'm not sure they may be entitled to more than 10%, and that would be different from somebody who has been admitted, discharged, and need a medical certificate or need medical evacuation, and they need a report from the institution. In that case, it's the hospital's patient, and you are, putting your professional certificate on the line and certifying that these are the true facts. So they may, in that instance, entitled to a higher percentage. So you need to recognize those nuances and be able to agree on some percentage appropriately. Over.
Thank you. Someone wants you to update us. Can you please update us on the car waiver? And then perhaps let me just take two or three more, and then you can address them. Then the other one is, please, do retirees also benefit from these described in your talk? And then finally, this is an appeal from Dr. Day. Kindly include lupus and rheumatoid arthritis on your list.
Okay, so I'll start with the last one. Kindly lupus and rheumatoid arthritis. Well, it's a representation that we'll pass the information on, but also with that, if maybe she could send is it Dr. Day that I know, my own colleague Jifa? If it's
Yes,
Jifa,
the one and only.
the one and only Jifa. Okay,
Yes.
so Jifa will have a chat. Maybe you just provide a one-page write-up, and then we can submit, and then why not? We are flexible. It's for our members. So why not? Anything that would inure to their benefits. The second one is respect to the car waiver. As a big one. Okay. So the car waiver thing is part of our conditions of service. When the new government came, they said they wanted to take stock. But remember that, or be reminded that the last day of the last government, the last batches were approved. So it was those that came after that are still in limbo. The difficulty that we face is their contention is that because the original waiver, application was not taken to Parliament for approval, they were having challenges. But I can tell you that that may be a convenient excuse, but it's also because of financial challenges and IMF conditionalities and all. But we continue to engage, and there's some understanding for some interim solutions so that we are able to clear the backlog that we have, and then we can dialogue on very comprehensive ways, which include tabling it for approval in Parliament and other things that will ensure the sustainability. But remember, be reminded and be reassured also that as GMA, we will do everything possible to preserve that provision COS. We can never be made worse off, and that will not happen. These are temporary setbacks, but we are hopeful that eventually it will be resolved. Vera, what was the last one? There were three: waiver, lupus, and then you've also forgotten yourself.
Retirees.
Retirees, yes. So, per our constitution, retirees are not required to pay dues, okay, to be members in good standing. However, if you want to benefit from the fund, then you should be paying the monthly deductions. So you must take steps to regularize your membership, even if you are not paying dues. But most importantly, you have to pay your monthly subscription to be a member. Over.
Thank you, Prof. York. I'm told Mr. Mpieni is here with us now. So, Mr. Mpieni, can you hear us, please? Are you here with us?
I can hear you.
Wonderful. You have so many questions here. So I'll put about two together for you to answer at a time. So we have here, can I sue a client for untoward behavior towards me? Can I choose not to attend to a client based on the client's previous bad behavior towards me? So that's one. And the second one is, among the barriers to customer care is poor remuneration or compensation. I did not see that if you did mention same. In this country where employers are pretending to be paying employees and employees pretending to be working, how does poor compensation contribute to poor customer care, and how can it be addressed? Mr. Mpiani,
Can I go on?
take these two. Yes, please.
Okay. Let me tell the first one. Whether you can sue a patient
for bad behavior.
on alleged bad behavior.
Mm-hmm. And whether you can choose not to attend to them.
There are two types of GMA members when it comes to legal suits. If you're an employee of, say, a service like Ghana Health Service, Kolebu, you cannot on your own sue a patient unless it's not official. If a patient misbehaves to you in the course of performing official duty, you must report the matter to your management. They have the right to take up the matter, whether they will resolve the issue amicably, internally, or take up the matter in court. But you, as an employee, cannot sue a client or the health service. Exactly.
Yeah.
The second is that if you are a private person, if you are a doctor, and then something happens outside the formal setting, that one it's your right to take up the matter. If you go to beer bar to drink and there's a fight between you and the beer bar attendant, the service has nothing to do with that altercation. It is between you and that person. But officially, if you are working as a doctor in any entity, public, private, quasi government, faith-based, and there's an issue between you and a client or a patient, you cannot on your own sue the person. You must report formally to the employee's management for redress.
The second arm of the question was
in
whether
Ghana
you
Health
can
Service, for
choose not
example,
to attend to the clients based on previous bad behavior.
You see, there's no contract between the client as far as previous bad behavior is concerned. Let me give a typical case. There's a case, Abba and Loco. Abba used to be a PA in one of our health institutions. And then Abba went to a bank to go and withdraw money at the end of the bank, at the end of the month. Then the security man at the bank saw that the queue was too long. And he knew Abba as the PA in the health center. So he called Abba and said, can you bypass the queue and go and take your money? Then Loco, who was in the who was attending the queue, and gave it to him nicely. Her nicely, insulted her, asked her to go and rejoin the queue. Abba went and rejoined the queue, got her salary at the end of the day, and went home. Then 2 weeks later, they brought Loco, the teller, who was in labor. Abba got annoyed emotionally and recalled the fact that when she was at the banking hall, the ladies did not spare her at all for jumping the queue. Wrote on her folder, patient doubts my integrity and professional ethics, referred to the next level. Then on the way, the patient died. You see, we should take note that there's no contract between you and a bank teller when you go to a bank or market and have any issue with your client. But if it's within the hospital, you are duty bound to attend the patient. If you are in a one-man station, it's even worse. But if you are in a station with other colleagues, you can call any of your colleagues to come and sign in for you because you are emotionally charged. And if it's not addressed, you make a mistake professionally. That's allowed. But if you're in a one-man station, you cannot say that I don't like this person because we fought in the town. You must what? Do your best what? Give palliative care to the patient. It's part of our professional hazards. You cannot say, I hate this person for I'm not treating. If he dies, you worsen your plight. So emotional challenge is one of the issues that probably in future we have to address. You cannot allow your emotional challenge what? Compromise your professional ethics. All right. Any other question?
Then yes, the next one is
I want to ask something, please. There, hold on.
Yes.
So yes, so Ms. Mpiani is spot on. I just quickly want to add that I mean, especially for emergency cases, and if you are the attendee, I mean the health professional, you have no choice. But for chronic care, and in a big facility where he mentions the availability of alternate care providers, I'm talking about individuals. It is well okay to say, can you can I let somebody else see you? Because you know, of the past experiences, and that is fair. You know,
Okay.
but if you are the only person, it is you are incumbent to take care of the person, and that is stipulated in the Hippocratic Oath, duty of care.
Thank you very much.
And you cannot renege on that. Over.
Thank you very much. I even mentioned that the revised teaching charter has provision that you cannot discriminate on grounds of social status. You bear a grudge with the colleague, you bear a grudge with the patient, and for that matter, when it comes to you, say you won't treat a person. It's a serious breach, and you won't be spared if it's reported. Thank you, Prof. York. Any other question?
Yes, the next one was on poor compensation and poor customer care.
Poor compensation, I think I mentioned earlier that we have condition of service. We have the collective agreement. And so if you employ me and you have to pay me 5,000, your role is to make sure that when the month ends, I'm paid my due fair. But you see, those of you who are in private practice, I always say that besides the salary that you pay your workers, you can do other perks to encourage them to remain in your employment. Some of them may be what? Allowing management to waive the rent of the workers in your department or in your facility. Occasionally giving them some prizes, deserving prizes. But if you're in the Ghana Health Service, you cannot on your own as medical superintendent or director decide to adjust the salaries of your workers. I mean, it can't happen. You need to go through the labor court, use the TUC, negotiate with your association like GMA for better condition of service. But once it's been signed between the employees and the employment agencies, you cannot change it as an individual. We all know very well that our salaries and remunerations are not the best, but once it's been signed and the government is paying, you cannot on your own change it. It will call for further negotiation with the GMA and the government, TUC in particular, to be involved. All right.
All right. If after attending to a patient and the customer is satisfied with the services and decides to show monetary appreciation or a gift, is it okay as a medical professional to accept it?
This is a dicey question. Well, people show appreciation for what they've done for them. I once went to US for a course, and then I met a foreign student who came for a same program for 3 months. In fact, she made me up. So she asked the husband that I should go and check out from my hotel. And for the 2 weeks I was in US, the lady and the husband paid all my hotel bills. It was a gift, but I didn't tell anybody. But you see, if you make it a condition that before I attend to you, you must assure me that if I'm done my treatment, you have to give me 5,000, like bribery. But we have not enforced rigidly tax on gifts. In the US, for example, if you are giving any gifts, regardless of the motive, you have to pay tax on it. I will not on my own encourage people to be using this as a condition before you attend to patients. But if on their own accord, they give you a gift, you can accept it.
So can I throw in some
Yes,
nuance
yes,
to the
Prof. Yes,
yeah, Prof, please come in.
So I'm just going to muddy the waters a bit. So you have situations where there's a queue for a particular type of surgery, and the patient sees the doctor, and the patient is aware that queue ni wa. You know, if you speak the right language, you don't be any more kakra.
Yeah.
So after the consultation, on can say me ma bribe, on can say me you, but you know, not the bed 10,000, 5,000 be at to table. Doctor, take this for lunch. What should we do?
Our advice that sex gifts should not be openly displayed.
Okay.
There was a case we handled. I won't mention the hospital and the Ghana Health Service. A farmer was booked for herniorrhaphy, and this doctor who was doing the surgery kept on postponing the surgery days. Then the farmer went and saw his in-law, who used to be a staff for the MBNI. The in-law went to bank and cut the 5,000, took notes of all the serial numbers, accompanied this in-law to the hospital. The day the man entered the consulting room, the doctor asked him whether he had brought the money. He said yes. He opened his small bag and brought the notes. In came the BNI operative and asked the doctor why he was taking that money, because he has paid already the official fees before even he was booked for the surgery. So he reported the matter to the Ghana Health Service Council. That time, Prof. Kome, you may know him, and Prof. Ankrabedu were members of the council. I was the council secretary. We invited this gentleman And he came and said he doesn't want us to pursue any legal issue against the doctor. I want him to be of good behavior, so we should call and warn him. So we summoned the doctor to appear before the council's ethical committee, and he admitted that he took 5,000. So these ones, I don't think we should encourage that. You see, if on your own you decide to support the doctor's work, you can pay in kind or in cash, but you don't openly display where you put it at on the desk or the table where there's a consulting nurse who may go around and even exaggerate what you have done with the patient. They are all legal, but you see, there are legal illegalities. Quote my former professor. He said there are legal illegalities. For example, Christmas, we know that people give gifts. So if you're in your house and he brings you a goat, you cannot refuse to take it. But where it is a condition, now I will not encourage you because you can be caught and they can embarrass you.
Yeah. So Prof, Mr. Bien, so I think you were right. I mean, there's no clear provision regarding gifts, of course, but once the law also provides that we should be paying taxes on which we don't do. But I think generally, I would say that the guiding principle should be: is this gift that I'm receiving going to influence the discharge of my duties?
Perfect. We can also add the legal provision for conflict of interest.
Yes.
Which probably we can handle it later on, but not for today.
So it's going to affect your decisions as to the care of the patient.
Yes.
So if it's answered in the affirmative, then you better have not take. But let's also remember again that these days with the preponderance of internet and videoing and all, which I said earlier, let's be careful.
They can record you without your knowledge.
Thank you.
All right, thanks.
Thank you. Thank you very much.
Any other?
Then we have, yes, Mr. Mpen, you have so many questions.
Hey.
So don't be in a hurry to leave. So we have
answer all the
30 more minutes.
I was giving 1 hour.
We have 30 minutes for the Q&A. So let's try and let our answers be.
I have hello.
Yes.
Let's be snappy. I have a virtual lecture with the University of Ghana business students, MBA students.
Quickly.
So let's take the
So I have from one attendee, I have an instance where a patient reported to authorities I disrespected her because I insisted the child stays on IV medication because the child was very sick. Because she is a client, I was told I was wrong to insist. When I feel I was just being passionate. And then I want to tie in with this second question here. Can I request to avoid reviewing a patient and allow others to avoid problems if the customer seems to have a problem with anything I do and I always find myself apologizing?
Okay. Let me start the first one.
Okay.
If you look at Ghana Health Service, where I know very well, we have code of conduct and certain procedures, and there's also a section for addressing all grievances, petitions. So, for example, in the case under review, if the patient goes to report to management, I expect management to do preliminary investigations. They should not just judge the matter. They must ascertain whether there's veracity in the allegation received by management from the patient. So I will fault management for just concluding allegation. Patients can exaggerate or embellish certain concerns, and if you're not very careful, you may side with them, and that is very wrong. So I sympathize with you that there was no thorough investigation in your matter. But in future, if they do something to you, you can petition to the next level that they've not dealt with you fairly. They did not adhere to the protocol for addressing petitions and allegations against staff of the service. So that's what I have for the first question. Then the second question is what I partly answered with Prof. York, that if you're in a one-man station, you cannot allow your emotions to compromise your judgment. He mentioned the Hippocratic Oath. It's spelled out clearly. Those of you who have forgotten should go and read it. It frowns on discrimination on grounds of the fact that you bear a grudge with the patient. You're not on talking terms. But if you are in a bigger institution where there are other colleagues, as we said earlier, you can approach one of them that, oh, I am emotionally charged with this patient, and if I go ahead with this treatment, I may make a mistake professionally. Can they hold a fort for you? Allowed. So bring in personal grudges in our professional work. All right. Any other?
All right. Yes. So how How do you deal with rude patients and patients who ask for your number such that you don't appear rude? And then how is the medical practitioner protected since all the points made here are client-centered? Is it possible we can have a presentation on that too? And then how do you handle a practice where one's professional treatment options are limited by the dictates of the medical insurance company?
Okay. So if we talk about the first one, rude behavior of a client, what do we do to the person? We have both patient rights and responsibilities, and we expect them to behave correctly when they come to our premises, when we are interacting with them. So if you have concern that the patient is very rude to you, report the matter to the police station, to your management for redress. If there's a need to arrest the person, they will do that. If he has assaulted, they can handle that one. Then your next question, patients asking for your telephone number. This is your private contact. You have the discretion not to give the number to the person. I've been doing a lot of CPDs. At times they ask my official number. That official one I can give you, but if I don't know you, I will not give my private number. What for? So denying the patient access to your private contact is not anything that will amount to rudeness. You can even politely ask the patient, what do you need that number for? And if he calls you and you think you don't need to answer the person, you can switch it off. If you call the patient and start telling something that you think is official, and you need to probably direct him to your office and capture all the details, you don't have to do that. Let me give a case that we handled years ago. There used to be a trauma surgeon in Ghana Health Service, one of our regional hospitals. His colleague, after 6th form, came on holidays from US. He called him and said he had been in Ghana for the past 2 weeks. He had just 1 week more to go back to US. And he needs a small medical report with a bill attached. If it can help him, he'll be very happy. Being colleagues in 5th form, he asked him to come to the facility. He came and he assessed him without the due process. Wrote a nice report, got a bill attached from X-ray, clinical lab services, pharmacy, among others. This gentleman went back to US and to continue his work. Then the US insurance company wrote to Ghana Health Service. I was then in charge of that schedule, that we should authenticate the report. I look at the doctor's name where he was working. It was one of the regions. So I wrote to the regional Data Health Services. I must refer to the hospital to find out whether the patient came to the facility as a former patient. They checked from their records, OPD, consulting register, pharmacy, clinical lab services, X-ray. His name was nowhere to be found. So they wrote to us. So I put a comment letter signed by the DJ back to the US that we cannot confirm that that patient was our patient when he came to Ghana. He must have had a private consultation without recourse to the service. Eventually, he was jailed for 10 years, I remember very well, for insurance fraud in the US. The Ghanaian trauma surgeon was referred to the Medical and Dental Council, and I recall he was suspended for 2 years. They don't allow him to work as a trauma surgeon in Ghana. I traced him. I got to know that he was in South Africa doing his own work. He came back to Ghana recently and died. So these are the issues. If you are going to treat the patient, please make sure that if you are working in a former entity, you go to the due process, capture all the documentation. So in the event of any challenge, you can defend yourself accordingly. All right. Your third question was what?
Briefly.
You should bear in mind that. Okay, probably continue.
Oh, Mr. Mpiani, please finish.
Okay. The third one was about the fact that some of the clients of the NHIA, the drugs are not covered by the scheme. If you study healthcare insurance with special reference to the National Health Insurance Scheme, they have 3 types of insurance schemes in Ghana now. We have the Ghana Health, the National Health Insurance Scheme, which was to call Mutual Health Insurance Scheme. Then we have the private commercial scheme. Then we have the private not-for-profit scheme. So if you go and insure with the NHIA, they have their own prescribed drugs that are from the EDL. And some of them are not covered by the insurance scheme. So if you go for a condition where the drug for the treatment is not in approved NHIS drug list, you have to pay. What we don't do is that we don't explain to the patient that the condition and the drug prescribed are not covered by the insurance scheme. But most of them, they go and complain that even though they are insured, they are in good standing. When they went to our hospitals, they have to pay for the drugs. That's the reason. So in the same way, the one who asked the question, if there's a patient you are treating and his prescribed drugs are not covered by the NHIS drug list, please tell the person that he can get a grant from the EDL or go and buy them from the open market. We need to explain to them so that they'll not complain that even though they are insured, when they came, you took money to go and buy their drugs. All right. Any question again? So I think you can come in with your contribution.
So no, I would just want to add about, people were concerned that the issues tend to be patient bias, which is rightly so, because you see, if you take any provider-customer relationship, the customer usually is favored than the provider.
Not to all extent.
I'm just saying that usually that is the case.
Usually,
I mean,
okay.
In terms of the expectations, I mean, if you go to the bank, it's a provider-customer relationship. So they see the client as right in the first, unless the other things that I'm just saying that your first
I agree with you. But majority of such cases are determined in favor of the patients. I agree with you.
Correct. But there's a way to also protect ourselves and to usurp our rights, as Ms. Mpini, have said. But just to add that documentation is one of the ways, to make sure that, when we are being held before a disciplinary proceedings, we may be vindicated, or proven right or otherwise. It is important, even when you are conversing, with the patient and suggesting treatments. One of the members said, you insisted that the patient receive an IV and they reported you. Truthfully, you can suggest, you can't insist. But if it's a minor, of course, then the parental consent comes in. But if it's an adult, he has the liberty to decide what he or she wants. So you can suggest firmly, and if this disagree, you need to explain to the patient, the pros and cons of the actions they want to take. And then you let them sign or make some documentation to that effect. Then you protect yourself. Over.
Let me add on to what Prof. Yoke said. If you are a patient and you request for discharge against medical advice, and it's you're allowed to go home. If they bring the same patient back in a worse condition, as a member of GMA, you cannot deny the person or treatment. You must treat him like it's an ordinary patient and document your findings. Don't get annoyed because of the fact that you cancelled him or her earlier and he declined to adhere to your advice and has come back in a worse condition. You must still professionally treat the patient. So that's the point I have for you. All right. Any other before we close?
Thank you. Thank you so much. There's just one more. You've addressed it in a way, but I'll just read it quickly. Can I refuse to see a client and have a colleague step in if, one, the patient is an adversary who wouldn't hesitate to litigate even the slightest drug side effect? Two, a patient who is a relative or someone close to me, and therefore it's uncomfortable to elicit sensitive information in the history and examination. So that's
okay. Let me start with the last one. Let's start with the last part of the question. We have what we call medical dilemmas. In medical ethics, we have what we call doctor dilemma. One of them is treating your very close relative, as we said. If you think that ethically it don't be right to treat that patient, refer him or her toward a colleague to handle. Because you get to know, as we said, all the confidential information about the patient. It's like going to do a surgery on your wife. You may even make a mistake. So such medical dilemma, please refer to a colleague who can handle them professionally. Then your department, who is always making noise, who is always speaking on your back. When you're having a meeting, you're not calling him or her to talk. Ethically and even legally speaking, it's not also right. So whether he's an adversary or not, if he's sick, he's brought to you for treatment, behave professionally. Said, take your mind back. That can affect the person. Bear in mind that they'll be holding you without your knowledge. So if you make it innocent, by the time you clear yourself, the inconvenience, the time wasting, be unbearable. So don't stigmatize patients that they are your adversaries. No, as a professional doctor, we have occupational hazards, and today's CPD is one of them. All right.
Can I just quickly add that we must also pick our battles. You see, you need to also be smart with these things. Whilst we can't always behave up to 100% of our expectations, we should also pick and identify issues that are likely to bring us problems. Okay.
Perfect.
Each person that you see as a potential adversary, every step of the interaction must be documented, and and make it in such a way that if somebody is reviewing it, they will know that you did right, including the time. Okay, including the time, and if possible, even have witnesses. Possibly, I mean, some of the engagements, so that you reduce the burden or your potential liability when you are called upon to answer. And also watch them that they tape you, they record you, and insist that they don't have the right to do that.
So as Professor York said, the catch word here is what? Documentation. Because if he says to record it, the judge can send for witnesses, medical witnesses. So if they review your documentation and you do everything professionally as expected of you, you will not have any case. And where there's poor documentation, they can indict you. All right. It's nice meeting you or working with you today.
Wonderful.
Close me so I can go and
so much. Yes, thank you so much, Mr. Mpiani. We've really enjoyed this session. Most of the other comments are all thank yous and appreciating all the informative pills that you have given to us. Thank you so much. We are truly grateful.
Welcome. Bye. I will send the presentation soon. So bye-bye.
Wonderful. Thank you. Enjoy. Have a great week. Yes, so Prof. York, the rest of the questions are yours.
No problem.
We have one here. Yes. Prof. York, nice presentation and a lot of good information on the welfare. However, there are a lot of your members as medical officers who haven't been posted for more than a year now. Hospitals are understaffed with people soon leaving for residency this September. Has there been any progress so far, or should they tighten their boots to seek for greener pastures? No, please. Prof. York.
Well, I mean, we can do as much, and what we are doing is to engage so that we get the financial clearances issued so that our members can be employed. I mean, it's unfortunate that a nation that lacks doctors, especially in deprived areas, will watch for doctors who who have received, funding for their training partly, to wishing to see greener pastures. But we will continue to press on. We are hopeful. I will engage the GMA president again after our discussion this evening, to get to know about the updates, and then we'll inform members appropriately. But it's something that we are not sleeping on at all. And rest assured, whatever we have to do as our part, as executives or as leaders, we will continue to do. Thank you.
Okay. All right. So another question here. Are we permitted, there are two questions actually from the attendee. One, are we permitted to have our personal receipts and issue it after rendering a service? Example, after signing a police form, I heard only last week that it is illegal to have one whilst your institution has official receipts. Then two, before COVID-19, a number of CPD points for most, if not all CPDs were stated so that members know exactly the number of points they will get from a particular CPD. But after COVID-19, I'm yet to see any CPD with the number of points stated. Okay, so this is not directly to Prof. York. Okay. So
let me start with the last one. The CPD points are always stated when it gets accredited by MDC. And sometimes when it is rolled out by the providers, it may not have been accredited. In that instance, they will not know the accredited or the assigned CPD points. But once it is accredited, the points are assigned and the providers know. If you attended any CPD and you are unsure of the assigned credits, kindly visit the MDC website and you will find them there. And just search for your topic. You will see the assigned credit. You can also ask the provider. They will provide if they have it. So it has not changed. What was the first one, please?
The first one was on personal receipts.
Oh, yes. I think what you come to know is the right one. You cannot have a personal receipt if you work in an institution. Okay. I mean, how do you reconcile that? Because your authority to see the patients is by the leave of the institution and through the ministry and through the government. So, I mean, it's not possible because, yes, it's a professional service, but it is the facility that is providing you with the patients and all the accoutrements that you need, including the table that you'll be writing on. So they are entitled to a certain portion of your income. However, if they decide to waive it, then fine. It's through an agreement, per agreement that you're entitled to 100% of those income, then so be it. But always try and route it through the institutional receipt so that when there's any issue, you don't fall foul. And earlier on, I'd mentioned that all incomes outside your regular payment or your wages or your salary is also entitled to be taxed. In this case, you are talking about withholding tax of about 7.5%. So if they decide to apply it, they are not wrong. And if they don't apply and the taxman comes, sometimes they will surcharge the institution. So these are the facts. Please, if there are other questions that were directed to Mr. Mpieni, and I may be able to answer them, so you can direct.
All right, wonderful. Sure. Okay. So this one says, thank you for an insightful presentation. A pressing concern affecting patients' care is the alleged refusal of some doctors and nurses to accept referrals due to claimed bed space constraints. This issue significantly impacts outcomes. As the Ghana Medical Association, I humbly request that you investigate these incidents and address them promptly. By doing so, we can elevate the quality standards of our healthcare services. So this is
GMA I mean, we'll continue to do what we have to do.
Prof,
no, it's not Prof, it's GMA. I mean, but the truth is that we can advocate, we would encourage, we would insist, we would tell our members, because our members to manage a lot of these institutions. So, I mean, that is where we come in and we have a role to play, certainly, But overall responsibility lies with the employer, who has to ensure that all these things are done. But please, wherever we find ourselves, in fact, customer service is not just the direct patient, doctor or health worker interaction. As Mr. Mpieni said, is a whole caboodle. It starts from the institution architecture itself, how you are received, social media engagement, complaints, customer interaction directly, the lab issues, bed space management. It also has to do with inpatient care and many others. So it's a value chain that's, as leaders in the health space, we must identify and troubleshoot where and how are we doing, or how are we doing badly or rightly, which areas can we improve to improve the patient experience. Otherwise, then there will always be trouble. This bed space management issue is an age-long thing. Many a time it's about lack of communication. There's a bed hiding somewhere on the wall that nobody knows. So they come to the ER and the ER is full. I have had the cost to go and sit in an emergency room many times just to make sure that a relative or a friend of mine gets a bed space. So it is real. Sometimes it is truly that there's no space. But also on many occasions, there's bed space somewhere that somebody can be moved. One of the things that happen, or we are aware of, is that the emergency care situation in this country is woefully underdeveloped. If you take Greater Accra, for instance, Kolebu Range 37, a few other private facilities, it is done. The other smaller facilities is just a small corner somewhere, sometimes with no monitor. It's just a drip and a stand. And, it is next to zero. All right. So everybody, when they are not doing well, Kolebu Range 37, and they get full. Okay, so as a general policy and as a nation, we need to think this through and improve emergency infrastructure, including human resource, to be able to manage emergency care. And this is part of the solution, as I said, it's not all the solution. Thank you.
Yeah, thank you very much. So I'll take these three together. One, what does retired and in good standing mean? That's the first question. Then the next one, please, when is the GMA Tier 3 contribution starting? Can an update be given on the development thus far? And then the third is, please, is the GMA Star Fund in force? So Prof. York, if you
I
can
hope
take
I
these
remember. So GMA Star
the-
Fund.
So the first one is, okay.
Let me
Okay, so
start with
maybe
the
you can
GMA
take
Star
that one
Fund.
first.
Yeah. So we were operating it, deductions were ongoing. And when the DDEP happened, everybody went on a chill. So, things dampened a bit, but we are picking it up. We've revitalized it. And what we are trying to do is to also get a source code from controller. Indeed, I have to announce here that we now have a source code for the staff fund deductions. And it's going to be voluntary. And now, because it's a tier 3 scheme, what it is that you enjoy tax benefits. So your tax liabilities are only applied after your GMA staff deductions, unlike other contributions that you make where the tax application is done before your contributions are made. So you make a lot of savings if you subscribe to the staff fund, and over time, it will really inure to your benefit. Please, the second one was?
When the tier 3 contributions will be starting.
So that's the GMA staff fund.
Exactly, yes.
Yeah,
so
technically, the GMA fund itself is also a tier 3, but it's also set in a different mode. But that is an ongoing thing, which has been around for decades.
Yeah. Then the last one was, what does retired and in good standing mean?
Oh, I mean, you are retired. You don't have to pay dues. And so, but you have to take an active step to register and have a registration with GMA as a bona fide member. And once you register, you're not required to pay dues. So that makes you in good standing. But to benefit or to be a beneficiary of the mutual health scheme, then you must go ahead and be paying your monthly subscriptions.
Okay. So then here we have, please, for the sake of clarity, is the 150 cedis per month for the entire monthly welfare contribution or just the new health insurance cover? And then to tie it into the next question, and what about pension fund?
Okay, so I'm sure these people probably joined late, but the 150 is to be a bona fide member of the GMA mutual health scheme with defined benefits that are projected earlier on. And it is not your regular malaria, hypertension, pneumonia thing. It's quite serious conditions, i.e. dialysis, transplant, and all that. That's costly, and you may also require being evacuated to a foreign jurisdiction for treatment. So that's the difference. GMA pension fund. What about it? What was the question?
I want to know what it is. How the total contribution is.
Which one?
For the GMA pension fund.
Oh, GMA pension fund, it's defined. I think it's 200 now.
So I think that Anani Frimpong has answered it in the Q&A that it's 300 per month.
It's 300 now.
Yes.
Okay, but you can top up.
Yes.
There are various channels to top up through Momo, through a standing order, and other channels that you find on the GMA website or the pension fund website. So you may be doing the statutory 300, but you can do a higher contribution if you so wish.
Okay. My daughter died 3 years ago in Kolebu. Am I still entitled to the 50% SMO basic salary package? And how do I go about it?
Hey, let's go. All right. I mean, I think we can have this conversation back though. Okay.
All right.
If you wish, you can still write, attach the necessary documentation through your divisional so that they verify, and then we'll take it from there.
Okay. Concerning the welfare, dues are deducted at source. So what is implied by in good standing? And then what are the various supports? What is the various supports at the level of SMO? I'm not sure if I get the question.
I also don't get it, but the deductions, yes, it's a source, but there are GMA, supposed GMA members who pay no dues, sometimes either deliberately or by no fault of theirs. That is why you should make sure that.
Prof. York,
Yes.
not to cut you, but there are quite a number of questions on what it means by being in good standing. So if you can really explain that, because I don't have to go over all, because there are quite a number of questions on good standing.
Okay, so
what
being a good standing member of GMA means that you are registered, pay your dues regularly, and you're also in good standing with the Medical and Dental Council. So at least the first two must be satisfied. Be a bona fide registered doctor in Ghana and a registered member of GMA who pays his or her dues regularly. That makes you in good standing or puts you in good standing as a GMA member.
All right. Then if a doctor dies but GMA was not informed, can it be done now to get the benefits?
I think we've answered this. Vera, you need to save some of those questions. Yes.
Yeah. Okay.
We answered it.
All right. So, thanks, Prof. York. Is the GMA considering liaising with other insurance companies for the welfare packages? Some have group welfare packages where a minimum of 40 people are required to start a policy, and each member contributes as low as 50 cedis for a year to benefit from various welfare packages like claims for disease.
We had one for a number of years with, I think, is it Premier Health also? Premier Health also. Yes. Unfortunately, there were challenges with the subscription. I mean, doctors demanded maximum benefit from it. And you know, because it's an insurance package, you need to put resources and put it together for you to use it for those who demand it today. You know, but as it is, the numbers of doctors that subscribed did not match the claims that were going up. So they wrote that they wanted to terminate it, which has been done, I think, since last year. And so that's the case. We've done that, right. And unfortunately, it didn't work out. Okay. Over.
Please, can GMA put out a list of salary for every level of doctor so individuals will know what they are required to receive from Controller and Accountant General when they are paid? Some people receive different salaries even though they are the same level with their peers. Thank you. Next one, great presentations. Does it mean this package is only applicable to government health institutions and private practitioners in private practice? Then the next question, are expatriate physicians still considered members of their association? And are they still required to contribute to the various welfare schemes, especially as many of Ghanaian faculty have been expatriates before?
Hey, I don't understand. The definition of somebody in good standing does not change. So, Vera, let me go over.
Yeah.
Good standing with MBA, registered member of GMA, and then you paid your dues. Whether you live in Ghana or you live abroad, that does not change. And those who want the salaries of doctors at various grades published, I don't know why we want to do that. And then I can understand where there are disparities, especially where arrears come in. But the disparities is not because somebody's being paid more than somebody for that deliberately. But even if you are all SMOs, there are steps along on the horizontal line that may be different. So if you stayed in the job for a longer time, though you are all SMOs, your pay points are different. Your salaries will slightly differ. And again, it depends on other things. Arrears that we paid may differ from one person or to the other, and therefore it may not be the same. Also, sometimes the controller itself make mistakes. And if somebody may get an extra 10,000, you think that he's gotten more than you. Eventually, when controller finds out, they take it back as retronet offsets. Sometimes we call it retrovirus. But you will chop it free. You will vomit it. Recently, it happened in a lot of the payments of the conditions of service applications that were made. So generally, the levels are all the same.
Okay. Please, can GMA Welfare consider reducing the interest rates and increasing the loan tenure to say 5 years?
The GMA office, the scheme, the GMA is welfare scheme, which is like a loan scheme or a revolving fund. It started at 21. Recently, it's been reduced to 18 based on certain representations that were made and the feedback they got, and the general fall in terms of interest rates and all that. But the last portion says something I've forgotten.
So increasing the tenure to say 5 years.
I think the maximum is 5 years.
The first one is about reducing interest, and the second is increasing the tenure.
I think it's possible to have it up to 5 years. They can get it. I will check before the meeting ends. Or those of you who are sure, you can put it across. But I think you are able to do up to 5 years. Yes.
Thank you. We'll just take a few more. There are so many questions. Please forgive me if I'm not able to read your question.
But I think we should do the last two.
Yes, last two. But quite a number of them are on posting of medical officers,
which you've answered.
Which we've answered. Yes. Am I required to pay arrears of dues after a hiatus on joining, say, military, and now reactivated my GMA membership?
Yes.
And then
the answer is yes. When you come, we work. We have some amnesty. You won't pay everything. If it says 5 years, it won't be. I think it's about a year's payment or so, and you'll be reactivated. But it's certainly not for free.
Okay. Are we entitled to speak to patients' relatives on phone at patients' request? And then, even though I said the last two, on a lighter note, why did GMA assume we will have only one wife?
I think the one wife thing, I also said it that I assume, it didn't say it. It didn't assume you have one, but it knows that some men have more than one wife. That is why it says only one surviving spouse in the case of a male. I know that there are a lot of people who are polygamous, so we are not calling any judgment on that. It's a right they have. We are just saying that we are only able to pay one surviving spouse in case it's a female or a wife, a spouse to a GMA male member.
All right. Yes. So I think we unfortunately will not be able to take the rest of the questions. Thank you so much, Prof. York, for addressing most of our concerns, for a wonderful presentation and bringing us up to date on all issues related to our welfare. So next we'll have our Honorable Chairman, Dr. Med.
Can I just have some closing remarks?
Yes, please, you can.
So I once again wish to thank you for indulging me and making me part of this afternoon's discussion. But it will seem from the feedback that a lot of the queries emanate from non-engagement, you see, on our various platforms. And please, I would admonish all of us to engage, on the various WhatsApp group, Facebook passages, Google pages, talk to our friends, and let's take active interest in what's going on around us. A lot is going on. And we as executive, have elected to do everything in our part to make sure that our welfare needs are met to the best of our abilities. The Dynamet has recently been launched a few days ago, and is a tool that can help all of us in our clinical decision making. Let's subscribe and enjoy the benefits. So thank you once again.
Thank you so much.
Yeah, thank you, Prof, and thank you, MC, and thank you, Mr. Broby. Okay, he has left us. We are so grateful, and the feedback is that this meeting, looking at the attendance alone, has shown that it was worth the efforts we put in as a committee. Please, am I audible?
Yes, you are, Chairman.
Okay, fine. So we thank you all. Time is fast spent, 10 to 6. So I won't engage you. I won't take too much of your time again, except to say the few things we need to bring to your attention. The next CPD will be on the 15th of June, next month, Sunday, same time, 3 p.m. The topic is contemporary issues and updates in women's health in Ghana. So we encourage all of you to book these dates and be available. Our CPDs, we think through them very carefully. The chairman was supposed to give some remarks, but it's not around. Dr. Winfred Barr.
I'm here, Chairman.
Oh, Chairman, you are welcome. Oh, we missed you from the beginning. Chairman, you are welcome. You are welcome. Yeah, so I'm doing work for you. You share your allowance with me.
Sure.
So we consult widely, SOGOC, SAFPOC, and all the groups in amongst us as doctors to make sure we get such topics which we think will benefit all doctors across the disciplines, including general practitioners. So that's what we do. And you realize that our topics, are quite unique. Now, I'll continue by saying that the division continues to work to promote the image of GMA and also whip up interests of doctors. So drawing from the last point of York, I think the engagement, we need to do more by engaging. As for executives, we can do so much. We have taken upon ourselves as part of our activities to be visiting institutions. Okay, but I know it's subject to time and all. Last year, we were able to visit Wijak Bawe, former Gasat Municipal Hospital. We were able to visit Botiano Polyclinic, executives, and then the other one, 3 institutions in that enclave. We interacted with the doctors, all of them with their management, and it was really helpful. We gave them information, we took their concerns and ideas as to how we can move GMA Greater Accra Division forward. This year, we'll be going to, I think, East, that area, Chimota Hospital, is same to interact with doctors and all, but our doors are also open. Reach out. Some people do so well from Chimota Hospital, from Pentecost Alpha Hospital, Police, and the rest. Also, get back to us, speak to us, ask questions, and let's make sure that our various platforms in the hospitals are very active. We recommend that every institution, you give us a name of your rep, okay? The one who will be a liaison between your institution and the division or the divisional, at the divisional level. So that when we release some of such information, the doctors are bereft of information. We don't have information at all, even about our own welfare. And that is not good. We don't even know what is due us. And we must also play a role in that part. Okay. Another key issue, which for me did not come out, I wish it came out better in this evening's presentation. We have feedback that we don't treat ourselves well at all when doctors become clients. Okay. And so I believe we'll take this up again, all by ourselves. The feedback, which we know about already, and no hospital is exempt. If you become a client, the way you are treated by a colleague doctor, by the institution, sometimes it's nothing to really write home about. So in that respect, let's do better. If a colleague needs medical attention, do your best but you see, you can't give what you don't have. You can't treat a client different from how you treat others. And so the topic is still appropriate that we consider healthcare, for everybody. But I think that for us, what the peculiarities are, we need to sit down and find out what at all is the problem. Because the problems are too many and the complaints are so many. Sometimes some of us have actually had such experiences. So we'll take that up. Now, a few activities that we engage in, we are going to meet the newly inducted House officers on the 8th of June. We do that. It's one of our regular activities where we guide them through the profession. Okay, we don't want them to run into trouble, create problems before we are called in to solve. So we engage them as to what's ahead of them in terms of practice, medical practice. We talk about ethics and encourage them to know everything about GMA and whatever exists to assist them to practice well. I'm speaking about institutional visits that we will do next month. Okay. And then I would also like to remind you, 13th month didn't come up. 13th month, almighty 13th month is there. The last council meeting in March, the update was that we're waiting for approval letter from the Director General of Ghana Health Service to sort of assist health facility heads to pay the 13th month. There are various modalities because, as you are aware, almost every healthcare worker in the hospital is entitled to 13 months. So every hospital and the way they manage to handle that. But most facility heads are requesting for the authorization, which I don't know whether it's been given yet. But in my own hospital, the Marginal Hospital, I have not heard anything favorable. We will follow up. And please do also follow up from your end and give us the feedback. A lot of things we're going to say about that on welfare, and I think Prof has done that for us and made the work very, very easy. So I will jump straight to some announcements, a couple of announcements, and take a couple of questions and probably bring the day to a close. Now, the first announcement is about, we lost one of our past presidents, Dr. Francis Edua Bebio. May his soul rest in peace. Now, the final funeral arrangements are out, and I would like to draw your attention. He will be buried on the 31st of May at St. Michael Catholic Church at Achim Buebia. And then the Sunday will be the Thanksgiving Mass, 1st June. So we encourage members who can to at least bid him a befitting farewell. And then the second announcement I have is 24th annual public lecture. It will take, it rotates in the divisions. This year, it's going to take place in Sunyani, specifically at the auditorium of Sunyani Technical University on Friday, 25th July, 2025. So those who happen to be around the vicinity, please kindly join the public lecture. The theme is going to be on Ghana's aging population, challenges in care and support. Okay, and it's going to be CPD accredited. So once you attend, you are assured of some CPD points. And then the final announcement I have is about the AGC, which is going to take the 67th AGC, going to be hosted by the Central Division of GMA. And note the date from the second week of November, that is 10th to 16th November. Traditionally, the CPDs, the AGCs have taken place in the first week of November, but this time it's second week of November, 10th to 16th. So the details will be given as to the details of the program and hotel information when the time gets close. So on that note, we want to give opportunity for maybe one or two, 3 questions. If you have questions directed to the division, I believe Prof is still on the call, we'll handle it. And then we have noted all the questions that have been unanswered. Okay. When we have opportunity, we'll tackle them for you, both to Mr. Brobe, to Prof York. And even if you have some for us and we are unable to handle them, we'll take them on again. On that note, I want to end and wait to see if there are any questions. MC, over to you.
Thank you very much, Chairman. I don't see. Okay, so how does one join the Greater Accra Division WhatsApp page? I've been okay.
Okay, so we will
And
just
then Chairman, let me just quickly add some here, please. What about malpractice insurance becoming very relevant? Don't know if Prof. York is still on the call. We can briefly address that.
I'm here, but what was the question? Sorry.
So it's just asking about, please, what about malpractice insurance becoming very relevant?
Yeah,
Yes.
I mentioned that briefly.
You touched it briefly, yes.
In the introductory remarks.
Yes.
And yes, the discussion started with our employers, but National Insurance Commission had engaged the Ministry of Health, and they also collectively had started some engagements with the unions. We met them, I think last year or so. Discussions have started, but even certain tariffs have been proposed, but it's not been concluded. It ought to be revisited. The issue is that the amount that were being proposed sound quite high, and we're hoping that the employer will bear the cost, but as it is, honestly, they cannot. So it may happen that the employees will have to also partly bear the cost, but to be truthful, the discussions have not concluded. So it's something we'll push for us to see a way forward clearly and communicate with you when we have the information. But let me also quickly add that on the personal level, if you wish to take one by yourself, please feel free to do so. But I agree that if we do it as a collective or as a scheme, it will be cheaper for all of us. And that is what we will continue to pursue. Thank you.
Thank you very much, Vice President and Chairman. It's 6:01 p.m. So we'll call it.
I think somebody wanted to find out how to join the platform. It's simple. Yes. Just submit your name to the admin, and the executives, all of us are admin, so and we just add you to the WhatsApp platform.
Yeah, but please, I will admonish the executives to do some background checks before.
Yeah.
And as much as possible, let's also try to avoid the joining of platforms or links. Sometimes it gets into the wrong hands. Okay. So let's verify that they are bona fide doctors, and then we can manually add them as much as possible. Over.
Thank you, Prof. Well noted.
Thank you very much.
Very well noted.
So we started with an opening prayer and we'll close with a prayer. Father, we thank you for bringing us to the end of this meeting. We thank you for all the insightful discussions. We pray that you will help make our practice better, and we pray you continue to preserve and protect us. In Jesus' name we pray with thanksgiving. Amen. So thank you all for joining us today, and see you during our next CPD / divisional meeting. Have a great week and a great month. Bye.
Bye.
Bye.